Good afternoon, everyone. Thank you so much for joining us today for this very important conversation on colorectal cancer awareness, prevention, and treatment. On behalf of Oncology Consultants and American Oncology Network, we are grateful to have you here with us today for our Facebook Live expert panel discussion. We're especially excited to bring together an outstanding group of physicians and specialists who are passionate about educating our community and improving patient care. At this time, it's my pleasure to introduce today's moderator, Dr. Yuval Raizen. Dr. Raizen is a respected medical oncologist with Oncology Consultants and will be leading today's discussion with our expert panel. Dr. Raizen, thank you again for being here, and I'll turn everything over to you.
Thank you, Allison. Appreciate it. Hello, everybody. Hope everybody is having a happy Thursday. Just wanted to introduce ourselves and introduce our practice, Oncology Consultants, and give kind of a bit of a background of why we're having this conversation in the first place and kind of the importance of talking about these things. So Oncology Consultants, we're a large medical oncology practice in the city of Houston greater area, as well as Corpus Christi. We've been a practice in this region for the past 43 years, and we are happily continuing to provide care kind of across the region. I've got some of my very close colleagues with me here today, so I will introduce them, and then I'll introduce myself, I guess, after them. Dr. Alkadimi, Dr. Munaf Alkadimi, is a medical oncologist and hematologist, and he actually has multiple areas where he practices across the city. So he's in our Texas Medical Center office, he's in our Pearland office, and also sees patients in League City and Pasadena. Dr. Alkadimi, if you want to say hi and say anything.
Yes, hi everyone, and welcome to this talk. I appreciate the introduction. So I mainly practice, as you mentioned, medical centers, Pasadena, League City, and Pearland, and I see a fair amount of patients with colorectal cancer. I'm happy to participate in this conversation with you guys.
And then my good friend and colleague, Dr. Angel Blanco. Dr. Blanco is a radiation oncologist, and he focuses from multiple sites, so treats patients in our Precision Cancer Center, which is at I-10 and Beltway 8 in West Houston. Also sees patients in the Northeast office, in Northeast part of town, where we provide radiation. Has also radiated patients in the Texas Medical Center and in the Greater Heights area, which is around 610 and Ella. Dr. Blanco, very happy to have you here. Anything you'd like to add to the introduction part?
No, thank you for the opportunity. Just to reiterate the fact that we're a multi-specialty group, and that is evident today, plus our associations with multiple surgical specialists that are around the city, and happy to be invited and honored.
Thank you, sir. And as Allison mentioned, my name is Yuval Raizen. I'm also a medical oncologist and hematologist. I practice out of two sites. My practice is in the Texas Medical Center and in Sugar Land. And like Dr. Alkadimi, I'm a general oncologist, take care of pretty much any cancer type. We certainly all have interests in different tumor types, and certainly have a lot of specific interest in colorectal cancers, and take care of anything that comes through the door, but certainly have a lot of interest in that tumor type. So, I think one of the things that's really important in setting the table for this conversation is really, why are we talking about colorectal cancer? And, as we get more refined and sophisticated in finding cancers and treating them, I think one of the really important things to realize is how prevalent this really is. And so, when we look at different types of cancers that affect people across the world, we see in the United States that colorectal cancer is actually one of the most common types of cancers, number one. And number two is the second leading cause of death in adults from cancer. It's next to lung cancer being number one. And one of the kind of disturbing trends that we've seen is that not only are we seeing a lot of colorectal cancer, but we're seeing it in younger and younger people. And so 1 out of every 5 people diagnosed with colorectal cancer now is going to be below the age of 55. And so we're seeing this not only being a very common cancer to be diagnosed, but one that we're seeing in younger and younger people. And the one positive thing about it is that it is a cancer that we thankfully have very good screening tests for. And so awareness and doing testing in time, a lot of the times can turn a cancer that is a leading cause of death into one that's extremely treatable and extremely curable. And so I think one of the most important things is just having awareness of it, knowing what we can do, not only to put ourselves in the best position to, number one, not get cancer in the first place, but number two, God forbid it happens, to be able to find it in an early stage and be able to cure it. And so I think that's maybe where we'll kind of center the conversation, and we'll hopefully be having a colorectal surgeon joining us if the operating room is cooperating. So we might have that as part of this conversation as well. And so, we talk about screening, we talk about prevention. Prevention is basically what we can do as individuals to put ourselves in the best position to not get cancer. Screening is doing testing that is able to find cancers in an early stage. And so the tests that we think about when we talk about screening, and very specifically to colon cancer, is colonoscopy is the kind of gold standard for testing. You might also hear about other tests, like tests of the bowel movements. So we call fecal testing, that's gained in popularity. We also, for other cancers, think of screening tests, for example, as mammograms and pap smears and prostate exams and PSA tests. So there's screening tests that are available for some cancers. Unfortunately, there's not screening tests available for all cancers. Colorectal cancer is one that the screening test is readily available, and one that's very important. And so, gentlemen, I don't know if anybody has any comments about screening. We'll maybe touch on that, and maybe Dr. Alkadimi, if you have anything you wanted to say about colonoscopy and stool-based testing.
Yeah, I do a lot of patients. I highly recommend the colonoscopy. A lot of patients, they don't want to do it. They don't like it. So we do the Cologuard test, which is the stool test. Some of the patients, they miss that. So their GI doctor, or we recommend the CT colonography is an imaging, as a CT scan. And that's what I usually recommend if they don't want to do the stool test or the colonoscopy. But I agree with you. The colonoscopy is the gold standard.
Yeah, they actually in recent years changed the age that we start doing screening for colorectal cancer. And it used to be that we'd start doing the screening at age 50, but that age has now been moved back to 45. And we found that thankfully most primary care physicians are very familiar with that. But I think one of the things that scares a lot of people is just the idea of going in and doing a test. What if I find cancer? And then not only that, even just the process of doing a colonoscopy. And so a colonoscopy, basically the test itself, is done by two types of doctors. So there's what's called a gastroenterologist, which is a doctor who's got a background in internal medicine, who's done additional training in gastroenterology, which is basically the field of intestinal disorders. The way that procedure is done is that a patient would take a medication or a series of medications, typically starting the day before the procedure, which would empty out their bowels, and basically involves having a good number of times that you got to go to the bathroom. And so that's not the most pleasant thing in the world. But the next day you would go in, the gastroenterologist would do a procedure where they would use a camera that's basically on the end of a long tube, a long hose that's inserted through the rectum. And basically they're able to look through the entire part of the colon. And the colon is also known as the large intestine. That basically is the part of our intestinal tract. The job of the colon, for the most part, is to take the liquid, the fluid out of our bowel movements as it's been digested through our small intestine. And the colonoscopy is really important because not only can they find things like cancers, but they can find precancerous spots, what we call polyps, which are tissue that can either be completely benign or tissue that's developing and potentially could become a cancer if it's not removed. And so that colonoscopy not only is used to find a cancer, but it's also used to prevent cancer. So if someone were to have a colonoscopy and have a polyp removed, that by itself could prevent someone down from developing cancer down the road. Now, people a lot of times, they'll tell me, I don't want to go through this. I don't want to have to go through drinking medicine that makes me go to the bathroom a lot. I'll tell you, I've had 2 colonoscopies myself. Can I say that it was the funnest day in the world? No, not at all, but it really was not that big of a deal. And the procedure itself is done under sedation. And so it doesn't hurt. You basically wake up after a nice nap and hopefully get a clean bill of health. But if not, then what you've done is that you've found something that potentially is discovered at an early point and can be treated. And so I'd strongly urge people to talk to their primary care physicians about when they should start doing colonoscopies. There's some situations where people should start doing colonoscopies earlier than that 45. We always talk about cancers as being either something that kind of just happens in life with unknown reasons. And then we also talk about cancers that are caused by inherited risks, what we call genetic risks. We know that people who have family members who have had colon cancers before, a lot of the times it's wise to actually start doing that screening even before the age of 45. If someone's had a first-degree relative, meaning a mother, father, or sibling who's had a colorectal cancer at an earlier age, they should actually start doing their screening 10 years younger than the time that that person was diagnosed. So if their family member was diagnosed at 45, they should start doing their screening at 35. And so that's definitely an important conversation, not just with your primary care doctor, but also with the gastroenterologist. We're very blessed to live in a city where we have a really large number of excellent, very well qualified specialists and people who can do this type of testing for you. And so definitely don't hesitate to do the screening. Now, another thing that we talk about is prevention. Dr. Blanco, Dr. Alkadimi, I don't know if you wanted to touch on that.
Yeah, I echo you about the colonoscopy, and always tell my patients, sometimes they can save you from the cancer. They found polyps and they resected, because sometimes the polyps will take 5 to 10 years to become cancer. Now, prevention, actually, studies show that regular physical activities, whether occupational, recreational, those can help reduce the risk of having colon cancer. Healthy diets, fruits, vegetables. We have recent studies published that ultra-processed food associated with the colon polyps and early-stage colon cancer in younger population. Smoking has a strong moderate to high intake of alcohol also has a risk of colon cancer. And there are some studies support using calcium, vitamin D, and folic acid to decrease the risk of colon polyps also. So just stay healthy, exercise, healthy diet, basically, less red meat, less processed food.
I'm going to take a 2-second pause and introduce Dr. Amit Agarwal, who is a colorectal surgeon and one of our close colleagues, someone who I respect enormously. Dr. Agarwal is a surgeon that works out at 2 locations in the city. So he also works out at the Texas Medical Center and Sugar Land. Dr. Agarwal is in and out of the operating room, actively taking care of colorectal cancer as we speak. But Dr. Agarwal, we're very grateful that you have a moment to join us here. We were actually just talking about prevention and screening for colorectal cancer, and we touched on doing colorectal screening. Dr. Alkadimi obviously just gave some blurbs about prevention. Anything you'd like to add about screening or prevention?
No, I think very important, and I tell all my patients the same thing, is that, just like women get pap smears and mammograms, it's very important for both genders to be getting colonoscopies. That's, my prevention. My diagnostic testing is colonoscopy. But I'd say for prevention, I will touch on some of the things that I just heard is, no processed foods, less smoking, good lifestyle, exercise, those kind of things, and less red meats will have been shown to decrease the chance of colon cancer.
Thank you, sir. I did mention earlier that the colonoscopies are done by two types of specialists. I mentioned gastroenterologists, but colorectal surgeons also do colonoscopies for screening. Just because you've seen a colorectal surgeon doesn't mean you necessarily need to have an operation. So Dr. Agarwal does a lot of screening colonoscopies. One of the things that actually is really important also to kind of set a difference, we use the word screening. Screening basically means looking at someone who doesn't have any symptoms, and you're trying to look for these polyps and look for cancers in someone who's not having any symptoms. There's a difference between what's called a screening colonoscopy and a diagnostic colonoscopy. So there are certain things that you should be paying attention to that would make you want to maybe not necessarily do that testing just because of a certain age, but because of the symptoms that you're having. And I think that's definitely something important to touch on. Dr. Agarwal, do you have any comments on when someone might want to really call their local colorectal surgeon or gastroenterologist to talk about doing colonoscopy?
Absolutely. I think that's a great point, Yuval. And what I would say is that, any alarming symptoms, whether that be abdominal pain or changes in bowel habits where you're, having normal bowel movements, but a little bit more constipated, or you're having more diarrhea, those are all alarm symptoms for you to go get checked out. Rectal bleeding is something that's very contributed to hemorrhoids, but it may not always be the case. And so if you're having persistent rectal bleeding, then you should be going in to get a evaluation and a potential colonoscopy.
Yeah, and I think that's really, really important. Pay attention to your body. Just because someone's having some constipation or even bleeding, it doesn't mean that they have colon cancer. But at the same time, it's also not something that should just be written off as, oh, I probably have hemorrhoids and there's nothing more to it. Definitely worth, if someone's having those types of symptoms, at least having the conversation with a specialist to just make sure you're not missing anything. And one of the reasons, again, why would we want to do this? Why would we want to do this more than once? Why would we want to do this frequently? Why do we want to check into these symptoms? Part of it is that, God forbid, there is something that's discovered. The earlier you discover it, the more likely we are to be able to get rid of it, and for someone to have to go through less to be able to be successful in curing that cancer. And so here you are talking to two medical oncologists, a radiation oncologist, and a colorectal surgeon. And one of the things that also we're very blessed to be in a city where we've got access to what we call a multi-specialty or a multidisciplinary approach. And cancer in general, a lot of the times is treated by a group of doctors, and not just the doctors, but obviously also the nurse practitioners, physicians assistants, nurses, and the whole team that's involved in care. But we've got a group of physicians that work very closely together to take care of this type of cancer. And so part of the question I'll sometimes get when someone comes to see me is, what is your part in this story? What is Dr. Blanco's part in this story? What is Dr. Agarwal going to do in my care? And it's very important actually to have a team of physicians that's in close communication with each other. Colorectal cancer, and especially rectal cancer specifically, it's very important to have this kind of multi-doctor team that's evaluating things and coming up with the most appropriate plan for you. And so as far as the role of each one of the physicians, I'll let each of you kind of touch on that individually, and maybe we can start with Dr. Agarwal, go to Dr. Blanco, and then go to Dr. Alkadimi as far as what the role of each specialty is in taking care of the cancer. And before doing that, obviously we're talking to a surgeon and a medical oncologist, Dr. Agarwal and Dr. Alkadimi. I introduced Dr. Blanco at the beginning as a radiation oncologist. And as you're discussing your role in the care, Dr. Blanco, maybe you can just give us a quick blurb about what radiation therapy is and how that's done and what role it has in treating colorectal cancer. So maybe we'll start with Dr. Agarwal.
Thanks, Dr. Raizen. So, for me, the diagnosis of colon cancer usually done by either, myself as a colorectal surgeon during a colonoscopy, or a gastroenterologist, either a diagnostic or a screening colonoscopy, found a colon mass. And then from that standpoint, then we get some staging done. And I think my colleagues will talk about that. But if the colon cancer is what we call stage 1, stage 2, then you're a candidate for surgery. If there's some stage 3, what we call locally advanced disease, then you may benefit from chemotherapy prior to surgery, or any distant disease of colon cancer. And so, involving the liver or the lungs and the colon would definitely necessitate chemotherapy first. But the goal is, to cure you with surgery with early stage cancer. And so those are the ones we operate on first. And just a little bit about how I at least do my surgeries is, we 95% of our cases are done minimally invasively. And so you have very small incisions. We use either the robot or straight laparoscopy to do these cases. And you enhance your recovery by recovering much faster. You have less infection risk, less hernia risk, and we get you back on your feet pretty quick. So that's the goal of cancer surgery, and that's what we strive for. But it all depends on the tumor biology. I'll pass it on to.
Before we move on, Dr. Agarwal, if
Yeah.
you do a colon, let's say you did a colon cancer surgery, how long does someone usually need to stay in the hospital?
So if you do it minimally invasively, which 95% of our cases are done, or my cases at least, probably in the hospital, average 36 hours, maybe a little bit more. There's 3 goals for me for you to go home, and having bowel function is one, tolerating soft food is another, and then you have to be on all oral or pill form pain medications. Usually takes about 36 hours.
Yeah. And you mentioned robotic surgery, so you mentioned minimally invasive. So maybe talk about for 2 seconds just the way that colorectal cancer used to be treated surgically, and kind of the larger incisions, and what it means to be using a robotic surgery.
Yeah.
I think that it's a really neat instrument, but obviously people sometimes will get the idea, is a robot doing my surgery? Is Dr. Agarwal doing my surgery?
Hey, great point, Dr. Raizen. So, in 1990s, laparoscopy, first came out, and we went from big open in surgery where you have an open incision, large risk for infection and hernias, and a lot of post-op pain, to doing it through smaller incisions. And so we now have transitioned in the early 2000s or late 90s into robot surgery. And so what happens is that the surgeon or myself is still doing the surgery. You have assistance from the robotic arms, but you control the arms at a console. And so what it really helps with is visualization. It allows you to have 3 arms instead of 2 arms. You have wristed instruments. You're able to sew a little bit better, more precisely with the robot. But I think the biggest key is the visualization. And so being able to see deep down in somebody's pelvis, if the uterus is in the way or the prostate is in the way, it's narrow down there. It's just a good conceptual field to be very precise in your surgery.
Thank you, sir. Dr. Blanco, tell us a little bit about what radiation is and what role it has in treating colorectal cancer. You're just muted. Grab your mute button.
Thank you very much, Dr. Raizen. So radiation is a third, one of the main 3 modalities in the curative and also palliative treatment of cancer. Palliative meaning for advanced cases where we treat for a symptomatic purpose, but here our focus is for cure. Radiation is not new. It is strictly an agent that damages DNA, much like chemotherapy, which I'll let my colleagues speak about. So in it, after surgery is probably the oldest treatment modality for cancers, because it postdates the discovery of X-rays in 1895. Within a couple of years, it was being already used for treatment-related purposes, and it's evolved into what it is today. Obviously, in the past, we used to use radionuclides and have subsequently evolved into electronic methods of production of X-rays, which is by far and away the predominant method of treating cancers with radiation. So what we do in radiation is essentially bombard healthy tissue and tumor tissue, but we're very selective these days because we have tools that better refine the focusing of the radiation. But essentially, a beam of high energy X-rays will traverse the body from multiple directions. And when they're concentrated near tumor tissue, they inevitably will sometimes collide with the nucleus of the cells, and that will produce DNA damage. And when tumors try to grow and reproduce, they are defective in many of their repair pathways and cannot proceed to grow, multiply, and metastasize. But because radiation is in a different nature altogether, it tends to be predominantly administered with an external radiation machine, which we call a linear accelerator. There are other modalities. There's internal methods to deliver radiation, which we call brachytherapy. There are also heavy particles like protons or in some cases even alpha particles or different particles that can also produce radiation and DNA damage. But the vast majority of radiation treatments in the United States are delivered with X-rays, and both hospitals and clinics like our clinic, Precision, use the latest technology equipment that is image guided and can be used to selectively target the malignant tissue. It has many advantages because in colorectal cancer, the main purpose is evolved to pre-operative use of radiation along with chemo to downstage the tumor tissues and make it more amenable to a complete resection. With that, we have limited our chance of local failure, which for the rectum, the bottom part of the colon, is especially important because the surgery is much more difficult and requires a different skill level, such as what Dr. Agarwal offers.
Thank you, sir. One of the things that a lot of my patients will ask me, and maybe you can touch on, is some of the fear of how radiation is given. So you talked about external beam and the treatment not necessarily being an invasive type of procedure. If someone's coming to see you for radiation, how's that usually given? What does the patient usually experience? How long does it take? And what do they feel while they're getting it?
Important points. So radiation is generally given on a daily schedule. The most common to follow the sequence here of colorectal cancer, which our main utilization is in the rectal cancers, that is typically given with what we call a fractionated course of treatment, which is daily treatment Monday through Friday for about 5.5 weeks. That's the most common. Shorter schedules exist, although for many reasons they're utilized less frequently, typically, unless for very specific purposes. So the radiation is given by patients who generally lying flat on an external machine. It is no different than patients getting a diagnostic CT scan or even an MRI, except that it's less confining than the MRI. The MRI, just to be certain, and does not involve ionizing radiations, but the CT scans do. The difference between the CT scans and the linear accelerators that are used for treatment is simply the energy, which is much more powerful. Patients don't really feel anything. The beam is agnostic to any symptomatology, but during the treatment, as the radiation effects accumulate, so the intestine gets a little bit irritated, the bladder gets a little bit irritated, and so does the rectum. So you can have symptoms like fatigue, diarrhea, decrease in the blood counts, and in some cases, nausea. I will have to say that the vast majority of patients, and that in numbers in the studies, about 95% are able to complete a preoperative course of chemotherapy with radiation. So while the side effects are certainly possible, insignificant, they're mostly moderate, and we've learned through the years on how to manage them effectively.
That's great. Thank you, Dr. Blanco. Dr. Alkadimi, what do you and I do in the treatment of colorectal cancer?
Yes, thank you, Dr. Raizen. So once I see the patient for the first time, either referred by his primary care physicians or colorectal surgeons or the gastroenterologist, first we'll talk to the patients, talk to the family, make sure he's aware about the diagnosis. Then I'll do a brief physical exams. Then we'll talk about what's the next step. Once they come to me, they are overwhelmed, hear the word cancer. So we take it in the steps. As I echo Dr. Agarwal, we start with the staging process, and the staging process usually including some imaging to the chest, to the belly, and the pelvis, and that's to let us know whether the tumor or the cancer is localized, or do we find any spots in the bone, in the lung, or in the liver that we need to biopsy with the needle through the radiology department to see if we have the same process, what's going on in the colon, going on in the liver, or in the lung. And that's going to give us an idea whether am I dealing with local disease, locally advanced, or metastatic disease, like me in stage 4. And I'll also do a simple blood test. I check the iron levels always. Most of the time they bleed. I check their kidney function, liver function. I check their blood counts as well, make sure they are not anemic. We also test the tumor marker, which is basically a protein produced by the cancer cell before surgery and after surgery, or during the treatment, to see if it's trending down or not, if it was elevated from the start. And then we'll do as you mentioned, the multidisciplinary team when we present our cases, where we have the colorectal surgeons, the medical oncologist, the pathologist, radiologist, radiation oncologists, and we'll all talk about the cases and present the case and what's the best step, and we give the recommendation. And if it's localized, I usually prefer to go through surgery first, then we'll decide. If it's locally advanced, if it's big tumor, if it's stage 3, some lymph nodes involved, most of my colleagues from colorectal surgery, they ask me to give 3 months of chemotherapy, try to shrink it down for better surgical outcome, and then followed by surgery. And if it is metastatic stage, then we'll talk about what are the treatment options based on chemotherapy, immunotherapy, targeted therapy.
So as you can see, there's a lot of different moving parts in treating the colorectal cancer. One of the other things that we do, which is not necessarily the treatment, is the watching of how things go afterwards. And so in addition to taking care of a cancer when it happens, it's also very important to keep up with this team or a similar team to just monitor thereafter and make sure that there's no signs that the cancer might have acted back up. One of the things that's really important to think about when we treat a cancer, Dr. Agarwal's skill in being able to remove the tumor is not able to address everything about a cancer. And so he's only able to remove what's in the colon itself and the surrounding areas. One of the things that's important to remember about cancer is that when it spreads in one of two ways, generally. Either it goes through the bloodstream or it goes through what's called our lymphatic system, which is a part of our immune system that's kind of connected throughout our body, where cells can start out from the colon itself and move to a different part of the body. The problem is that the testing that we have available in this day and age is not powerful enough to see whether someone has those microscopic areas of spread. And so we talk about stages of cancer, and Dr. Agarwal mentioned stage 1, 2, 3, 4. And the reason that we use the stage is really more than anything to give us a sense of what the likelihood is that someone might have microscopic spread of that cancer. You heard Dr. Alkadimi say that with a stage 3 cancer, we're likely to recommend that that person get chemotherapy. And what it means that that cancer is stage 3 is that the cancer is moved into the nearby, I like to describe it as the drainage system of the colon, which is called the lymph nodes. When Dr. Agarwal does his surgery, he removes a number of lymph nodes from around the colon, not because he's picking them out individually, but they come out as a part of the sample. And we see, has the cancer already moved into those lymph nodes? And what you can imagine is that if the cancer has already moved into the lymph nodes, that means that it's at least trying to spread. And there's a higher chance that microscopic tiny cells have already migrated to another part of the body. And that's a place where we use, as an oncologist, we would maybe recommend taking something like chemotherapy, which is basically medicine that gets into the bloodstream and goes everywhere. So no matter where the cancer cells might be lurking, that chemotherapy can potentially kill those cancer cells, again, by damaging their DNA, and prevent them from ever causing a problem down the road. So even if someone has that microscopic spread, it doesn't mean that they're destined to have the cancer come back later on. And so that's a big part of what we use chemotherapy for, in part to prevent the possibility of a recurrence. We also use chemotherapy in people with more advanced colon cancer where it's already spread somewhere else, which you heard the other doctors describe as being stage 4, or the term metastatic, which means having already spread. And so that's where we use chemotherapy and other types of treatments like immunotherapy in certain situations, or targeted therapy, which is a different type of treatment that we use to try and control the cancer as best as possible, with maybe not the possibility of curing it, but with a lot of good successes in a lot of cases in keeping that cancer under control. Now, moving on to another issue that I think is really important, you've heard us talk about colon cancer, and you've heard us use the word colorectal cancer. And so, Dr. Agarwal, if you could maybe give a kind of brief description of what's the difference between the colon and the rectum?
Yeah. And so I would say, both of them are part of the large intestine. So the rectum is the last or distal part of the large intestine. And so, the rectum, from where the anus starts and moves upward, it can be in centimeters, can vary from female and males. And so, we say anywhere up to 18 to 20 centimeters from the anus is truly the rectum, and everything above that is the colon. So anything above 20 centimeters is usually the colon. Everything below 20 centimeters is the rectum. And so you have two different physiologies of those two types of cancers, and different treatments and different algorithms that we use to treat colon versus rectal cancer. And so that's my brief overview of that.
And it becomes really important because there's a reason that we kind of differentiate the two. We could really just call it all colon cancer because, as Dr. Agarwal says, the rectum is truly a part of the colon. There's a couple of different points that are super important that make it important to treat them in a different way. So part of it is really just where it is in the body and where it is along the digestive process. Remember, I'd said earlier that the colon, it's taking out the fluid from the bowel movements. And when the digested material's on the right side of the colon, where it's just come out of the small intestine, it's pretty much all liquid at that point. As it's traveling through the colon, it starts to get more and more solid. And once you're down into the last part of the colon, into the rectum, that's where the bowel movements are completely solid as we're used to seeing them when they come out. That becomes really important in what a tumor in that area could potentially do. The other part that's really important is where it is in our body. So our colon is basically sitting entirely in our abdomen, whereas our rectum is sitting in our pelvis. And as Dr. Agarwal has to deal with, the pelvis is a much tighter and more narrow space. One of the amazing things that we've seen with our skilled colorectal surgeons is the ability to do these operations and remove cancers that are lower and lower down in the rectum, and still be able to reconnect and reattach that colon so that someone can continue to go to the bathroom as they've always been used to doing. But you might have heard of something called a colostomy before. A colostomy is where basically the surgeon creates almost a detour where that colon is emptied out or opened into an opening in the abdominal wall, and the bowel movements come out into a bag. There are some situations where that's not avoidable, but one of the situations where it's more possible to need a colostomy is when the cancer is in the rectum. So typically when someone's diagnosed with a colon cancer, they'll see Dr. Agarwal, and the first thing that he'll do is, after doing all the tests to make sure that the cancer hasn't spread and that the person's in good enough condition to go through a surgery, is he'll do an operation. And then we'll decide after the operation, in most cases, whether someone needs any more treatment. But when it's a rectal cancer, we approach that differently. And in those cases, a lot of the times, we'll have a conversation with a team just like you're seeing here, where we'll decide whether it's right for the surgeon for Dr. Agarwal to first just go and do that operation, or whether it makes more sense and puts the patient in a better position for success to actually give some treatment beforehand. And that treatment usually involves Dr. Blanco's radiation, Dr. Alkadimi or my chemotherapy, and sometimes the use of those things together even before doing the surgery, and in some cases afterwards. And so as you can see, colon cancer and rectal cancer have a lot of similarities. And in fact, if you looked at a colon cancer under the microscope and did the Pepsi challenge and set them next to each other with a colon cancer, there wouldn't be a difference. It's the exact same type of cancer cell, but it's really where it is that makes it different how we treat it. And so, that was my talk about treatment of colorectal cancer. I think, we're about 40 minutes into the conversation. I want to definitely leave some opportunity for some questions if there are any. Allison, I'm not sure if there were any questions from the audience.
Yeah. Am I on? Okay. Yes. Actually, we have a couple of questions that were sent early, but we did have a question come in as you guys were talking. It's from Monty. Monty, thank you so much for your question. Does family history increase my colon cancer risk, and should genetic testing be considered?
That's an excellent question. I'll let Dr. Alkadimi or Dr. Agarwal answer that question.
Yes, more than happy to answer. So yes, if you have a first or second degree relative, if they have a colon cancer, stomach cancer, yes, there's a risk. So usually we do have our geneticist and oncology consultants. They can ask you simple questions about your family history, who has the cancer, what type of cancer, and there is a specific panel of genetic tests that we send through the blood test and see if you have the risk or not.
Thank you. And, there's actually even new recommendations that recommend that anybody diagnosed with colorectal cancer who's less than 50 should certainly undergo genetic testing as well.
Okay, we have one question that came in early is how has treatment for colorectal cancer improved in recent years, including targeted therapies and clinical trials?
Yeah, that's excellent. I think you'll see that the treatments from each one of the doctors in front of you have become more advanced over the years. Dr. Agarwal, you did touch on the advances of the surgical techniques, and what we've seen is in the hands of a skilled colorectal surgeon doing a robotic surgery, we're seeing significantly improved outcomes, and certainly add anything to that. Dr. Blanco will maybe have you touch on some of the advances in radiation techniques and what's different. And Dr. Alkadimi, I'll let you touch on some of the novel therapies for colorectal cancer.
The radiation treatments have also evolved. There's two principal differences. Number one, the use of image guidance, and that has really revolutionized our ability to be able to decrease the margin of normal tissue that we used to treat versus what we treat now. And the other big advantage has been the development of more conformal methodologies to deliver the radiation, meaning that as we now outline the tumor volumes, it used to be done in a rather crude two-dimensional way, but now with three-dimensional planning, the highly sophisticated software and treatment deliveries that are part of our linear accelerators can actually shape the radiation much closer to the shape of to match the shape of the target tissue, and that really decreases the side effects. So radiation has relatively stayed constant. I mean, the effect of ionizing radiations is as such, and the linear accelerators were developed as post-World War II advancement back starting in the 50s with the Stanford linear accelerator, for example, that became a commercial company. But today our refinement consists of better imaging, better targeting, and decreased side effects primarily.
Great. And Dr. Alkadimi, tell us what's changed about chemo, and then maybe touch on immunotherapy and targeted therapy,
Yeah.
and when those come
So
into
we
play.
do have the conventional chemotherapy, which we're using. That's the backbone. But in certain populations, certain types of colon cancers, if they have certain mutation, like if your cancer cell acquires certain mutation, we can use a targeted therapy. And they found to have a better disease-free survival, will make you live longer, be in remission longer. We also have the immunotherapy in certain type of rectal cancer and colon cancer, which we can give right now and after surgery or even in metastatic setting, and has excellent response. From the rectal cancer, actually, the data showed 100% of the patient had a complete response with the immunotherapy.
Yeah, the advances in the treatments has been spectacular, and it's been personally very rewarding to work in a time where we've seen significant advancements in the care of all cancers. The word chemotherapy, I know, is a very scary sounding one, and one of the things that's changed about chemo is not even necessarily the medications that we're using, and there certainly are newer drugs that have been developed, but the way that we give them, number one, and the medications that we give with them to both help and support through side effects. And so the whole idea, and Dr. Blanco was touching on this as it relates to radiation, but we're trying to give treatments that are basically killing the cancer cells while sparing the innocent bystanders. And that's something Dr. Agarwal is doing physically as part of the surgery. That's something we're doing with our medications and treatments, trying to avoid the damage to the healthy cells. And so the way that chemotherapy works is basically we give you a medication. That medication goes through the bloodstream, and it's trying to kill what we call fast reproducing cells. So cells that are copying and dividing quickly are the ones that are the most kind of at risk or susceptible to the treatment. But that's where the side effects come in. And so chemotherapy damages the cells by interfering with that process of copying, usually by damaging DNA. Immunotherapy is something that's really revolutionized cancer care, and the way that it works is basically using the body's natural immune system to fight the cancer cells. And one thing that we've known for a very long time about cancer is that a lot of cancers are very sensitive to the immune system. There's two problems. Number one, the immune system has a natural kind of blockade to how much it can do. And number two, it's a lot of the times it's not able to really find the cancer cells. And so they've developed medications that have kind of helped to overcome that. Now, most patients with colorectal cancer are not candidates for immunotherapy. It only works in a very specific group of folks who have genetic changes either in the tumor or in their own genetics that show that it would be sensitive. And there's the same thing with targeted therapies. As cancer care has become more and more advanced, we've learned that treating cancers is not always just based on treating it as a colon cancer or a lung cancer or a breast cancer, but also looking at the genetics, at the changes in the cells in the cancer itself. And sometimes if someone has a specific change in the cancer, or in other cases when they don't have a specific change in the cancer, there are medicines called targeted therapies that can work really well in addition to or instead of chemotherapy. Now, those are usually used in more advanced colorectal cancers, ones that are already stage 4 or metastatic. But we've got a lot of new tools, and there was the question about research. Research is certainly something that allows those therapies to continue to be developed. Now, within Oncology Consultants in our own practice, we do a lot of clinical research. We have clinical trials that range anywhere from kind of the later phases where we're trying to figure out how well something works compared to the standard of care, and all the way down to research studies that are trying to figure out whether a treatment works at all or what the right dose is. And so clinical trials are certainly a part of these treatments and are not always appropriate, but in some cases certainly can be. Allison, you're on mute.
There we go. Thank you. We have another question. That's a great question. Is diverticulitis disease a risk factor for developing colon cancer? And thank you, Morgan, for your question.
I've got a great colorectal surgeon sitting next to me who can answer that one.
Yeah, that is a great question, but there's no true link from diverticulitis to colon cancer. Now, the people that have diverticulitis usually have more constipation, are not eating enough fiber, eating a lot of red meats, and can those indirectly lead into colon cancer? The answer is yes, but there's no direct link from diverticulitis in developing colon cancer.
That actually, just a jump off point on that, Dr. Agarwal, this isn't necessarily a cancer question, but a lot of the times when we do a CT scan as part of the staging of a colorectal cancer, we'll see the term diverticulosis. Can you explain to us what the difference between diverticulosis and diverticulitis is?
Yes, absolutely. And so I think that's a great question because as you mature and age, the colon wall gets weaker if you're not eating enough fiber and you're getting constipated, you're straining to have bowel movements. So what happens is your colon develops these pockets, and those pockets are called diverticulosis. When those pockets get inflamed, with stool being stuck inside one of those pockets, then it becomes diverticulitis. And so that is inflammation of that pocket caused by some type of blockage of that area, whether it be stool or it could be a foreign body, sometimes a popcorn kernel, or whatever it may be. But when that area gets inflamed, that's when it is called diverticulitis.
Thank you for clarifying.
We have a question from Christy for Dr. Blanco. What are the side effects of radiation therapy when treating colon cancer?
So to make the distinction again, radiation is not used very commonly for treatment of colon cancer per se, but more for the rectal cancers because of the surgical accessibility that was touched on by the panelists very elegantly. But radiation has two effects. Number one is a systemic effect, which means a general feeling towards the body, and that is mostly fatigue produced by cells trying to repair the damages from the radiation and chemotherapy, which is usually given concurrently or at the same time with. And then the second side effect, which is important, is that radiation has acute effects on the healthy tissues that are adjoining the tumor. So in the case of the rectum, that would be diarrhea from adjacent intestines, or also irritation of the bladder and the prostate to some extent. Long-term side effects can be produced by scarring of the bowels, that we call intestinal fibrosis, or also some degrees of sexual dysfunction and impotence, which is an important point for our ever healthier or younger colorectal cancer population. Severe side effects during radiation treatment now happen in less than 5% of patients, however, and that has to be taken into account when we analyze the counterweight, which is the big pressure that having a cancer diagnosis exerts on the overall health of the individual.
Allison, were there any other questions cooking?
There we are. Yeah, we do have another question from Letty that I think a lot of people want to know. After treatment is complete, how often does a patient need to follow up?
Yeah, it's a great question. It varies from case to case. So there are guidelines that we all follow that make recommendations of the best way both to do treatment and surveillance. And the general guideline is within the first 2 years that a patient would have a follow-up every 3 to 6 months. Followed by in years 3, 4, and 5, doing a follow-up every 6 months. Generally, during those follow-ups, there's the same tests that Dr. Alkadimi was talking about earlier, where we do some blood tests. people a lot of the times will ask me, is there a test for cancer? Is there a blood test that tells me I have cancer or I don't have cancer? And unfortunately, that doesn't really exist. The tests that we use are basically looking more for hints that there might be something going on. So Dr. Alkadimi had mentioned a tumor marker. There's a marker that we follow, which is called CEA, or carcinoembryonic antigen, which is a protein that is produced both by colorectal cancer as well as other cancers. But the important thing to know about it is that it's not just cancer that produces that. And so in some cases, we'll do blood testing and that test will come back slightly abnormal, but it doesn't have anything to do with cancer because there are healthy tissues that produce CEA. And so we follow that. And as someone comes to see us, typically what we do is for those visits, we're going to do a physical exam. We'll talk about symptoms. We'll do the blood tests. And then we'll also include doing imaging. Imaging is basically CT scan. Now, depending on the stage of the cancer, that's going to help kind of change the timing and frequency of that testing, but it's generally done at least annually for the first 5 years. In some cases, it's not done at all. So, for example, in stage 1 colorectal cancer, it's not always done, but certainly can be. And then the other thing, it looks like we lost Dr. Agarwal. We'll see if he was able to join back on or if he had to run to the operating room, but there he is. Dr. Agarwal, if you could maybe comment on the follow-up as far as colonoscopies after someone's been treated for colon cancer.
Yeah, and that's also a good question. And so, the guidelines say 1 year after your surgery that you should be getting a colonoscopy. In my personal practice, though, I think, and what we've seen for any high-grade colon cancer with high-risk features, I try to get them in a little bit earlier than a year and try to get it done in 6 months. And so 6 months from the surgery. And if they're standard colon cancer and I'm not really worried, then we do it a year. So the guidelines do say 1 year, but we've been able to push that up to 6 months after the surgery.
Now, when you do those colonoscopies, you're obviously looking at the part of the colon where the cancer was and you reattach things. What else are you looking for?
So any other growths in the colon, people that are high risk, family history, had multiple cancers, you want to make sure there's no other polyps or growths in the colon that have developed over that period of time. And you definitely want to check that connection that you made to make sure there's no abnormal cells growing in that area or there's no recurrence of cancer.
So that becomes really important just as far as how often he's going to recommend that you do the colonoscopy. Some of that's going to vary depending on what's seen on that colonoscopy. So someone who has a lot of polyps probably should get a colonoscopy much more frequently than someone who has no polyps. Now we're coming down to the last couple of minutes here of the event. Allison, maybe time for one last question. If not, we can wrap things up. Sorry, Allison, you're just on mute.
Thank you. You're a good moderator. Harry has a question. How do you determine which test to use to detect biomarkers for somatic mutations?
Well, so just to define the terms somatic versus germline, that's an important thing for anybody who hasn't heard that term before. Somatic basically meaning a mutation that's in the tumor itself, as opposed to germline mutation, which is within our own DNA. And so when we talked about genetic testing in people with family histories, that's what's called germline testing. Now, the testing for mutations in the tumor itself, there's some things that are done as a standard by the pathologist. The pathologists are the physicians who get the sample from Dr. Agarwal and dissect it, look at it under the microscope, do stains on it to determine, number one, what type of cancer it is, whether it's cancerous, and what type of mutations are there. And that decision-making is generally done by the pathologists. Now, Dr. Alkadimi and I, when we've got a case of a more advanced colorectal cancer, will a lot of the times do advanced what we call molecular profiling, or what we call next generation sequencing, that's looking for a host of different genetic mutations within that tumor. And there's a number of different companies that do that, and are commercially available. There's a number of those companies that are used more frequently, and typically we go with the ones that we trust. Now we're coming to the end here. We've got about 30 seconds, so I just want to take the opportunity to thank everybody in the audience for joining us. Hopefully this was a helpful overview. I really want to thank Dr. Agarwal, Dr. Blanco, Dr. Alkadimi. You three are people who I greatly respect in your fields, and anybody who needs a good colorectal surgeon, a good radiation oncologist, a good oncologist, and I say good, I mean amazing. These guys are top of their fields, and so I appreciate everybody joining us, and we hope this was a valuable experience. Thank you so much.